So welcome to week 7. We're going to start out talking about conditions of the blood. We'll do a quick Kahoot, then we'll do the GI section, and then we'll do another Kahoot. As always, if you guys have any questions, please let me know. So generally speaking, when we talk about the blood, we're talking about the cells that are formed in the blood. You need to kind of be able to recognize the medical terms for different parts of the blood and also the layman's terms, and then to really recognize that a lot of the blood products are produced in the bone marrow. So the bone marrow is a very important part of red blood cell production, and also to recognize the name of this hormone here. So on the bottom right of the screen, it says erythropoietin. So this is a hormone that our body naturally produces, and it stimulates the production of red blood cells. So if patients have like leukemia or the types of cancer where they have a low level of red blood cells, or even patients like sickle cell patients that don't produce healthy red blood cells, sometimes we'll give them this protein, and that stimulates their body to produce more red blood cells. And then we're also going to talk a little bit about the lymph system, and the lymph system really is involved in fighting infection. I'm sure you guys have all felt like the lymph nodes. So if you ever feel a child's lymph nodes and they're swollen or inflamed, then you should definitely be suspicious of infection. It's not normal for kids to have enlarged lymph nodes unless they have an infection. In addition to the lymph nodes and the lymph drainage system, the spleen is the biggest organ or the biggest part of the lymphatic system, and it gets enlarged during infections, and it also is producing some of the white blood cells that we use, so the lymphocytes that are found in the lymph that's used to fight infection. So we'll talk about the spleen on and off throughout this lecture. The main thing that you kind of need to recognize is it is important in fighting infection, and also sometimes in different disease processes there can be problems with the spleen, and sometimes they end up taking the spleen out. When we talk about our circulating blood, we really talk about two different parts, like the cells and then the plasma, which is the liquid portion. So the formed elements, you definitely need to recognize these three terms. So does anyone know what an erythrocyte is? What's the other word or other phrase for erythrocyte?
Red blood cells?
Red blood cell, very good. And then leukocytes are also white blood cells, and then thrombocytes are your platelets. So these three things you need to be able to recognize, either one of these terms. So, if you ever have a test, oh, I'm sorry, I can't type. And you see the word erythrocyte on there, then you need to recognize that means red blood cell. And the red blood cells are their primary function in life is to transport oxygen. So they contain a protein called hemoglobin where the oxygen binds. So, this is their main function in life, is to make sure that oxygen gets delivered to the tissues. And then the leukocytes, the white blood cells, for fighting infection, and the platelets we use in clotting. So these are the formed elements of the blood, or the main cells that you see in the blood. So anemia is just a general term that talks about a low hemoglobin. And since you have a low hemoglobin, which is that protein that oxygen binds to on your red blood cell, then you don't have the same oxygen carrying capacity. So patients that have anemia, regardless of the cause of anemia, they tend to be pale, they tend to be weak, and they breathe faster because they don't have the same oxygen carrying capacity. So they're trying to get more oxygen in. Sometimes they can feel short of breath, and sometimes they can develop congestive heart failure. So this congestive heart failure is something that you see if you have untreated anemia that goes on over time. Does anyone want to postulate, to try to tell me what you think about why you develop congestive heart failure if you have chronic anemia? How does your body respond to not having enough oxygen?
Or
Or
is it
decreased
because the
oxygen?
heart's working to compensate to get oxygen throughout the body?
Very, very good. So, you might, right, exactly. Since you don't have the same the number of hemoglobin, which is where the oxygen binds, you don't have the same ability to get oxygen to all your target tissue. So then your heart has to pump faster and harder to get that oxygen out. And over time, that causes congestive heart failure. So this is one of the things, we talk about anemia, iron deficiency anemia, and sometimes we talk like it's not that big of a deal, but really if you're anemic for a long time, then you'll end up with problems with your heart. It leads to congestive heart failure. So iron deficiency anemia, we've talked about it a couple times in this class. This far and away, this is the most common type of anemia in children. And we talked about a couple of reasons. So who can tell me why we don't want to give cow's milk to children under a year? Why does that lead to anemia? What's wrong with cow's milk?
It doesn't have all of the iron and everything that they need to develop.
Yeah, very good. And it's also that it's harder to digest. Sometimes don't have the same, they don't have the same ability to really break down lactose. So they can end up with microscopic bleeding in their GI tract, which can also contribute to the anemia. So it doesn't have the nutrients that they need. And it can also, it's harder to digest. It can cause some GI bleeding. So you definitely need to be able to recognize that why we don't give cow's milk to kids under a year, and that giving them cow's milk is a risk factor for developing iron deficiency anemia. So this just goes over, basic information. We talked about it previously, how they look if they have anemia. And these on the right-hand side of the slide, it shows you some of the blood tests that you would expect to be ordered when you're working somebody up for anemia. So, and as I mentioned, that, it's in the short term, it's something that usually is pretty well tolerated. But if it goes on, their heart muscle become weak, they have congestive heart failure, they cannot grow as well, and might affect their brain, their ability to think. So usually you start with diet modification, but if they need iron supplements, it's usually 2 to 3 times a day. You guys have probably heard this before, that vitamin C aids in absorption. So if they're at the age where they're able to drink orange juice, it's a good idea to give folic acid or ferrous sulfate with orange juice. If you don't give it with orange juice, then it's best to give it on an empty stomach, because then your acid levels are the highest and it's more likely to be absorbed. So a couple of points. Always as a nurse, you're thinking about anticipatory guidance and education. So really stress the importance of either breastfeeding or iron fortified formula for the first year of life, not giving any cow's milk. If they take any iron supplements, the parent should be warned that it can change the color of their stool. It can make it kind of green. And then you can give it on an empty stomach, or maybe with a vitamin C liquid, but not with milk, because that'll alter the absorption. And just to make sure parents know that it's not uncommon for kids to have iron deficiency anemia, so they should expect to kind of maybe be screened for it at a well child visit and get follow-up if there's any evidence of anemia. And then we're going to talk about 2 different types of anemia that are genetically inherited. Has anyone heard of sickle cell disease or known someone that had sickle cell disease? Yeah, I see some heads nodding. You guys have probably heard of it before. Can you guys tell me which ethnic group is more likely to have sickle cell disease? Is it prevalent in all? Huh?
African Americans.
Yeah, African American. And what is it? What's the general principle behind sickle cell disease? People that have sickle cell disease, what's wrong? What causes them to not feel well?
They have low platelets, right?
So it does affect their blood, but what it does is that go ahead. Yeah.
I'm sorry. Instead of the cells being round there in like an awkward cellular shape, then that's
they're like in the S, right?
Yeah. So they don't have the same oxygen carrying capacity. So the cells that carry their oxygen, and specifically their hemoglobin that's on that cell, it's sickle shaped. So it's kind of shaped like a crescent moon instead of being round. So very good. And since it's not round and popped up, it doesn't have the same ability to bind oxygen. So they have a decreased oxygen carrying capacity because of the misshapenness of their their hemoglobin, of the red blood cells that carry oxygen. And also because they're not shaped the right way, they're more likely to stick together. So I think that's probably where you got the platelets, because when you have platelets, you use platelets to form clots, but people with sickle cell disease also form clots. And that's because their hemoglobin is not the right shape. So then it's more likely to stick to other hemoglobins and they form these blood clots. So the blood clots, they also cause those red blood cells to be broken down. So if you imagine that you have like a thin, small vessel, like in your kidneys or in the toes, as you get to like the extremities of your body, your blood vessels get smaller and smaller. And if you get blood clots in those small vessels and the blood continues to go through there, that it just kind of breaks those red blood cells up. So their red blood cells don't have the same oxygen carry capacity, and they also break down their blood cells more quickly. So they have anemia for a couple of different reasons. There's this word down here at the bottom of the slide. It's hemoesteriosis, and I apologize for my pronunciation, but I would recognize that this is iron deposits. So your hemoglobin contains iron. So when you break down your red blood cells, you end up with iron deposits throughout your body. So sometimes you have to take medication to get rid of that excess iron. So you'll see this throughout this lecture when we're talking about the breakdown of red blood cells and different types of anemia. So sometimes people with sickle cell disease have this problem where the iron builds up in their organs and they have to take a chelating agent, we call it, which binds to the iron and helps remove it. So this is a genetically inherited disease. So if you get the gene from both parents, then you have sickle cell disease, where if you get the gene from just one parent, then you have what's called sickle cell trait. So some people are asymptomatic when they have sickle cell trait and they don't even know they're a carrier. And then some people have mild symptoms. And then if you get it from both parents, then you have the symptoms.
Sorry, you said that the asymptomatic one is the one when it only comes from one parent?
Yeah. And then they have what they call sickle cell trait. Yes.
Okay.
So if they get it from both parents, if they inherit the gene from both parents, then they have the disease.
Yeah, my mom has sickle cell. I have the trait.
Oh, okay. And how do you feel pretty good for the most part?
I get like body aches and pains sometimes, and like my
Yeah.
iron is low.
Okay. And how is your mom doing?
She passed away from it. It was like
Oh no.
they didn't really have like medicine and stuff like that back when she was living. So
Oh my
yeah.
goodness. I'm so sorry to hear that. But now that it runs in your family, so you guys can get tested.
Yeah, we do. I had to, like, for my kids and stuff like that, we had to get tested.
Yeah. Yeah, it's really thank you so much for sharing. It's one of those things that it just breaks my heart because like like your mom, I don't, I know it must have been painful for you, but it's so sad because they're like normal people, they have normal lives, and then they have this disease that came out of nowhere that they probably didn't even know they were a carrier for. And it makes it hard. They have a lot of chronic pain. So I'm glad that you shared that with us. It's really nice to be able to talk to someone that has some experience, take a little bit more of a personal face. And your kids are all doing okay?
Yeah, so they ended up not having the trait at all,
Okay. Oh,
which
good.
was good. So I guess it's not as bad. I think one of my children may have the trait, but not all of them.
Oh, okay. Yeah, and they know and so then the one that has the trait can get tested if he or she wants to have a partner in the future and maybe have kids. If you know about it, then you can kind of plan your fertility and stuff like that to try to prevent people from developing the disease. But it's really it is one of those things that it's kind of like, for me, it's kind of like this, or cystic fibrosis. Like sometimes you don't even know it runs in your family, and then it really has a big impact on your life.
Yeah, my mom died at young, so I grew up knowing that I had the trait. So it was always in my plans. I knew about it.
Yeah. Wow, that's powerful. So even if but even if you did know for whatever reason, usually it's diagnosed pretty early in life. Like you would expect within their first year, even people that didn't know that they were carriers, usually there's symptoms that ends up getting diagnosed. So sometimes the initial symptoms are just going to be swelling in the extremities. And then it and can end up causing, more severe symptoms, obviously, over time. When they have that clumping of the cells, then they end up with more pain and more symptoms as they get older. So they, when they have sickle cell disease, they can have what they call a sickle cell crisis. And this is really related to those blood clots forming and not getting oxygen to their tissue. And it's very, very painful. When it happens, they can get infections in that area because they're not having normal blood flow. So they can't get their immune response to wherever their clot is. They're also at risk for a stroke because they have all these extra blood clots. So it can be really problematic for people. It's a lifelong disease that really needs a lot of management. So there's 4 different categories of the sickle cell crises. So the vaso-occlusive, that's where they form those clots and it's very painful. Splenic sequestration. So there's a lot of blood vessels in your spleen. And if you get a bunch of clots in there, then the spleen doesn't function normally. So they can cause a crisis in the sense that your spleen's not able to work, not able to help you fight infections. Aplastic crisis, this refers to problems with your bone marrow. So your bone marrow produces your red blood cells, and then if you have an aplastic crisis, you're not able to produce those red blood cells anymore. And this hyperhemolytic, this is referring to the rapid breakdown of the red blood cells. So the most common that we think about the most is the vaso-occlusive crisis, but all 4 of these can happen to patients that have sickle cell disease. So the primary therapy, what you're always trying to do is have them have as normal life as possible. So this is this hormone that I mentioned at the beginning of class, the erythropoietin. Sometimes they give that to sickle cell patients and that kind of increases their bone marrow production of hemoglobin. Sometimes they get a splenectomy, but it's not done that commonly, but they frequently have problems with their spleen because they end up with that splenic sequestration where they get those clots in their blood vessels of their spleen. Because the spleen is really important for fighting infection, you have to be a little bit more careful. They're at risk for infection and getting sick because of that problem with their spleen. And also dehydration, if they ever get sick, they almost always need to be on IV fluid. They're just at higher risk for forming clots. So you need to make sure their blood is staying thin, keeping them adequately hydrated, and then low oxygen because of their problems with their hemoglobin, and the sickling is that clumping of their cells. And here's that word again that I have a hard time pronouncing. Hemosiderosis is where they have the release of iron from their hemoglobin that builds up in their body. And this deferexamine is the name of the medication that they can give to chelate or bind that iron, then help remove it. So having this iron build up throughout the body can damage your organs like your liver. Does anyone have any questions about sickle cell disease or sickle cell anemia? There's another type of anemia that's also genetically inherited. This one's not as common in the United States. This one is primarily in people of Mediterranean descent, so like Italy, Greece, that area of the world. And it's the thalassemia. And it's similar to sickle cell disease in that if you get the gene from both parents, it's a much more severe disease than if you only inherit it from one. So the 2 forms, thalassemia minor is going to be you inherit the gene from one parent, and thalassemia major is also called Cooley's anemia, and that's where you get the gene from both parents. There are rare occurrences where it's from a spontaneous mutation, so some people have thalassemia without receiving the defect from their parents. And it's very similar in the sense that they don't produce normal red blood cells, so they're small, they don't work normally, and they get broken down easily. It's not the same shape, but it's a very similar concept. So they have a lot of the same symptoms. With thalassemia, they tend to be, the thalassemia major, they're even more anemic. So even if they're not diagnosed prenatally, or if they don't know it runs in the family, you're going to expect a diagnosis within the first 6 months of life. I'm sorry, within the first year of life. So the kind of similar to sickle cell disease. And the primary treatment for thalassemia is repeat blood transfusions. They just don't make functioning red blood cells. So they tend to just need a lot of blood transfusions to keep their hemoglobin at an adequate level. And this is one, you would expect them potentially to have congestive heart failure, et cetera, because it's like this really chronic anemia that doesn't go away and they need these repeat blood transfusions. So for these, we talked about the fact that, your red blood cells come from your bone marrow. So sometimes people with thalassemia that major, the Cooley's anemia, they actually have like misshapen bones because their bone marrow is trying so hard to produce enough red blood cells that ends up changing the shape of their bone. So they can end up with, dysmorphia in their face, changes to how their face looks because of this constant bone marrow stimulation to produce more red blood cells. So there's usually a family history, but like I said, sometimes it's a spontaneous mutation. And the main therapy is to try to get them up to a adequate hemoglobin level. So you do repeat blood transfusions. And this is the same thing. They can end up with sequestration. They can have problems with their spleen. So sometimes they end up getting a splenectomy. And because of the number of transfusions, they're also at risk. I think they're at higher risk for this iron deposits. So they get this medication that we talked about with sickle cell disease that helps chelate or bind that iron and move it out of the body. So this is
about the splenectomy, but you said they don't do that. It's not like they try not to do that, right? But it's pretty much like when it's down to the wire, that's the last thing left that they can do.
Yeah. And it's also, they try not to do it because it doesn't necessarily help them in any way. Like a lot of times it's damaged because of all the sequestration. But if it's, if it's not working and they're having a lot of problems, and also there's clots in there and those clots can then build more clots, and they'll just go ahead and take it out. But it's not the first line. It's not something that they do right off the bat. They try to leave it there as long as possible.
Okay.
And the same thing, kind of similar to thalassemia, similar to sickle cell disease, is you have to prepare them. This is really a lifelong illness. They're going to need medical management from ideally a whole team for their entire lifetime. And it's, it can be really challenging because these kids tend to not feel well. They're going to need a lot of medical care. So the family needs a lot of support. And like I said, in the United States, I can say I've taken care of a bunch of sickle cell patients in my lifetime. I never took care of anyone that had a thalassemia. So I think that it really kind of depends on your patient population that you're working with, but sickle cell is more common in my experience. Do you guys have any other questions about the thalassemia or the sickle cell? Thank you for asking. Always speak up if you have questions. We're going to kind of move on to the hemophilia. So hemophilia is a genetic disorder where you don't form blood clots normally. So this is like, there's a wide range of how bad hemophilia can be, where sometimes patients have a hemophilia where if they get a small cut, they can bleed to death because they really don't have the ability to clot. And sometimes they just need a little bit of extra pressure to help them form a clot. So there's a wide range of how bad a hemophilia can be. But the main thing that you need to remember about hemophilia is that the treatment is to replace the clotting factor that they're missing. So it's genetically inherited. They don't produce a specific clotting factor. And if you give them that clotting factor, then they're able to clot their blood. So we kind of talked last time, there was the Duchenne's muscular dystrophy as a disorder that's like, in males, it's like X-linked, so the mom passes it on to her male son. So this is the same sort of inherited sex-linked recessive trait for hemophilia. So moms are carriers, and then they have sons that have the disease. So you see hemophilia in boys, and it's the mom that passes the X chromosome onto her son. And this is, what's wrong is that they don't produce a specific clotting factor, and the treatment is to replace that clotting factor that they're missing. So, they have different names. So like hemophilia A is going to be caused by a deficiency of factor 8. So everyone is going to have its own clotting factor that's associated with it. So, I said there's a wide range. For some patients, they could, a minor scratch or bumping their arm or whatever become life-threatening. So you really need to know where they fall on that spectrum. And the aim of therapy is to, you know, replace their missing clotting factor. So a lot of times, sometimes they have to go in like to a specialized clinic where they get their medication, but they're also changing it to more home care. Sometimes parents are learning to give their medications at home. They do a lot of monitoring, so they'll be monitoring what their clotting time is. So, you know, a normal clotting time is like 3 to 6 minutes, but for some severe hemophilia, it can take up to 1 hour. To just kind of have that in your mind, that there's really a wide range of how bad somebody's hemophilia could be. So obviously, depending on the severity, sometimes they can end up in death. You always have to be worried about severe headache. That could mean like they had an intracranial bleed. Vomiting also goes along with intracranial bleed. All of these can be signs that they've had a bleed into their brain. So if they have hemophilia, you always have to be cognizant of what neurosymptoms you need to watch out for. And since there is such a wide range, if you're ever working in a pediatrics office, a pediatrician's office, or, you know, having conversations with parents, if they really say, you know, my kid gets a lot of nosebleeds and they just won't stop, that's something that you really need to pay attention to, because that could be a sign of a hemophilia that's not diagnosed. So, or if you're giving them immunizations and you notice they get a bruise that's really bad, or they bleed at the injection site. Another thing that might happen is they could have like a lot of chronic joint pain. So they could be bleeding into like their knee and their hips. And then they ultimately get diagnosed with hemophilia. So just to be aware that it's kind of like a lot of these genetic disorders, not everyone knows that they're a carrier. So you could be a woman that's a carrier, you could have a male child, have no idea that you're a carrier, and then your child has these problems with bleeding and they end up having hemophilia. So just kind of to be on the lookout for what the symptoms are so you can intervene, give appropriate education. Most of the time it is given IV, you replace the clotting factor, depending on what form of hemophilia. There are some nasal sprays, DDAVP, can be given to some patients to help stop bleeding, and it gets absorbed through their nasopharynx. So these kids are almost always in a multidisciplinary team. You know, they've got like a social worker and a physician and a nurse that really knows the disorder well and helps the family. There's a fine line. You know, you want your kids to socialize and have their really good peer group and be active, but then if they could get really hurt and have problems because they cut themselves, it's really hard to let them be autonomous and develop that independence. So that's really the main struggle that you're going to help families through, is that, you know, allowing them to be kids with also making sure they're still safe and giving them all the education they need about, you know, how bad their hemophilia is, monitoring their clotting time, and making sure they're staying compliant and getting the medication that they need. So the last thing that we're going to talk about is platelet disorders. Do you guys have any questions about the hemophilia before we move on?
I would just say when it comes to that one, because there's so many different factors to it, that when you have a little girl and she starts her period, to pay close attention to that, because it wasn't something that I even thought of. And then my daughter was having really bad complications and now she has to see a specialist. She is missing a factor. So it causes,
no way.
yeah,
Oh my goodness.
her periods are horrific and she's on medication for the rest of her life that helps to clot it so that her period, yeah.
Wow.
I didn't have any.
Yeah, I'd never, I mean, yeah, because most hemophilia is, like I said, the mom passes it on to the son. So your daughter is missing a factor. That's really interesting. It is really, I mean, I think I'm so glad that you shared. I would say, like, in general, when you're working in pediatrics, you should always take your parents seriously. Because, you know, a lot of times parents will be like, my kid has really heavy periods. And you're like, yeah, right. But no, like, you know, your kid, you know, if it's really heavy, and sometimes you really have to advocate for yourself. Did you have to tell the doctor multiple times that she was really having problems before you were believed?
No, actually, I had got a new pediatrician when we moved here, and I told them what was going on, and they got her immediately to a pediatric blood doctor, and he took her levels. She was really low. She was very, it was low. Didn't matter what I was feeding her, what I did, and so she had two options. She could either go on a birth control that would need it. And I was like, nope, we're not putting a hormone into her body. And then there's another medication that she's actually on. There's no hormones in it, but she will have to take it for the rest of her life to help her with her periods.
Wow. Well, thank you for sharing. And I'm really glad that you were able to find a pediatrician that listened to you. That's I'm happy to hear that. It's good.
Yeah.
So thank you guys for the sharing. It always makes it a little bit easier to like remember the information if you can kind of pace it with a particular patient or a particular scenario. So I really appreciate that. So for platelet disorders, platelets is part of your formed parts of your blood, and they're used for clotting. So obviously, if you have a platelet disorder, we're talking about usually not enough platelets. So then you're going to see signs of bleeding. So the petechiae are those little teeny tiny red dots that you see when there's blood under the skin. Purpura, ecchymosis is bruising. So just to be aware that these are the sorts of things that you see if you have a patient with a platelet disorder. What we think about in pediatrics in terms of platelet disorders, sometimes you'll see platelet problems in patients that have leukemia or something like that, but the most common thing that you're going to see in pediatrics is something called ITP, which is idiopathic thrombocytopenia purpura. So this is, it's like an autoimmune reaction to a viral illness. So kids will have a cold, or an upper respiratory infection, and then after they get over that, you'll see this bruising and bleeding. And the body starts attacking their platelets. So they break down their own platelets. You see it primarily in younger kids between the ages of 2 and 4. Some of the classic thing that you're going to see is, easy bruising. So the MMR vaccine covers rubella and rubeola. But it can happen after other viral infections also. So this is one of the reasons why we really want to make sure people are immunized, they get their vaccines, because it does decrease, the viral illness itself, and then sometimes these rarer sorts of autoimmune reactions to viruses. So, I'm sorry, moving my mouse around too much on my screen. A normal platelet level is going to be like 150 to 400,000. So when you have ITP, you can expect a platelet level to be below 20,000, so quite low. So if you needed to confirm the diagnosis, it would actually be from a bone marrow aspiration, but a lot of times it's based on symptomatology and how they present and how low their platelets are. So whenever you have a clotting disorder, platelets, hemophilia, whatever the case is, your neurological assessment is a priority of care. You're always going to be worried that they could bleed into their brain. So if they have ITP, they need close neurological monitoring. So they use medications that you would expect with an autoimmune disease. So they give prednisone, they give gamma globulin to help tamper down the immune response that is causing the body to attack their platelets. You can end up with chronic ITP, but it's not very common at all. Usually kids do not require hospitalization. They have this problem, it's self-limiting, and then it goes away in a couple of weeks. Occasionally they need to be admitted to the hospital to be monitored more closely. And all of these drugs here, aspirin, caffeine, phenacetin, all of these cause or make it more likely for you to bleed. So you're going to avoid these drugs if you already have a platelet problem. And generally speaking, even though the platelets are low, you almost never give platelets to these patients because they're in this autoimmune process where they break down the platelets. So if you give them platelets, they will also break down those platelets. So it doesn't really serve much of a purpose. Sometimes they will be admitted in the hospital for really, really close monitoring if their platelet levels are particularly low. So any place that you could bleed, that would be a complication from ITP. So you can have GI bleeding, you could bleed into your joints, you could have an intracranial hemorrhage. And then, like I said, the rubeola and rubella are covered by the MMR, but it can also happen in response to other viruses. So making sure kids are all up to date on their immunizations can prevent cases of ITP because it's an autoimmune response after they have a viral infection. Do you guys have any questions? Okay, we're going to do a quick Kahoot, and then I'll give you guys another break. And then we'll do the last chapter. All right, which food is rich in iron? Bananas, carrots, cream of wheat, or egg whites? All right, so good job. Yeah, sometimes people are kind of drawn for the carrot, and egg white's not. The egg yolk has iron, but not the egg white. Cream of wheat is the best answer. So which statement by a mother may indicate a cause for her 9-month-old's iron deficiency anemia? I give her a cracker to chew on. Formula is so expensive. We use cow's milk. She eats a lot of fruit, or she almost never drinks water. Yeah, very good. So the milk for a 9-month-old, cow's milk, not good. GI bleed, a little bleeding, not enough iron. Very nice. What should the nurse closely assess in a child receiving a transfusion? If they have lethargy, if they have fever, if they're jaundice, or if they're bradycardic. All right, so we didn't talk about this, so I'm impressed at some of you. So I know as LPNs, you probably won't be giving blood transfusions. Sometimes you can monitor patients once the transfusion's been started. So when you ever a patient's getting a blood transfusion, you worry about a transfusion reaction. So the main thing you're going to be looking for is fever. Also, itching, hives, and backache are kind of the classic signs they could be having a transfusion reaction. So the fever is the thing that you're going to pay the most attention to if they have the transfusion. So the nurse notes that a 4-year-old has bruising and petechiae on his extremities. What lab value does the nurse suspect? A leukocyte count of 14,000, a hemoglobin of 8, a hematocrit of 36, or a platelet count of 25,000. All right, good job. So petechiae and bruising, you're going to be worried about a platelet disorder. So this platelet count of 25,000, that's too low. So that's the thing that you would suspect. So a child is diagnosed with iron deficiency anemia. What will the nurse explain can occur if the diagnosis goes untreated? Patient could develop heart failure, pulmonary embolism, infection, or hemorrhage. All right, very good. Heart failure, worry about congestive heart failure long-term with anemia. So a child with leukemia has widespread purpura and a platelet count of 19,000. What is the priority nursing intervention? So we didn't talk about leukemia, but any patient with a platelet count of 19,000, what is your priority intervention? Place a PIV, assess the neurological status, monitor vital signs during a platelet transfusion, or educate the family on preventing bleeding. Yeah, so a little bit split on this. Whenever you have a platelet count of 19,000, this is really low. You're worried about bleeding. So assess neurological status because you want to make sure that you pick up early if there's any evidence that they've had an intracranial bleed. It's your highest priority. What would the nurse include in a teaching plan about mouth care for a child receiving chemotherapy? Use a soft toothbrush, avoid using a water pick, inspect the mouth weekly for ulcers, or use a commercial mouthwash. All right, good. So I think you guys know when you're on chemotherapy, you're at risk for mouth ulcers. So the soft toothbrush is a good thing. You're going to expect it a lot more often than weekly. You usually have a prescription mouthwash, and a water pick is good. It helps clean their teeth. So an adolescent with Hodgkin's disease is crying and states, "I am so scared." What is the best response by the nurse? "You shouldn't feel that way. I understand how you must feel. Tell me why you're so scared," or "You should talk to your parents, not me." All right, good job. Open-ended question, getting the adolescents to talk, even if you don't know what Hodgkin's disease is, you still want to make sure that you're, giving the adolescent space to talk about why she's scared. Yeesh. So the nurse is caring for a child with a low platelet count. What skin assessment would would alert the nurse to bleeding? Ecchymosis, hematoma, petechiae, or all of the above?
All the above.
All right, good job. All of the above. Okay, nice. Thank you everyone for sharing and participating in class today. I'm gonna go ahead and we'll do the podium, and then I'll give you guys another quick break. All right, nice job, everyone. So when I post the lecture, I'll post the Kahoots for you guys to practice too, and then keep a lookout. I'll send an announcement out. Keep a lookout for a Kahoot later in the week to help you guys study for your quiz next week also. So it is 10:17. So go ahead and come back at 10:30 and we'll finish the class up.
Professor? Can you hear me?
Hey, everyone, when you come on back from your break, please flip your camera back on.
Professor, I don't know if in the last part of class, I had some issues with my computer and everything kind of booted me out. I couldn't see anything. So I don't know if it showed me outside of the class or not, but I was here the whole time. I had to restart everything.
Is this Jessica?
Yes.
Okay, yeah, I'll take a look at the log just to, thanks for letting me know. Someone sent me a message, so, but
Okay.
I'll look to make sure you get your credit.
Thank you.
Yeah. Looks like most of you are back with your cameras on. Okay, so we're going to go ahead and get started. Let me make sure that I'm still sharing my screen. Oh, wait. So we're going to go ahead and talk about the GI tract. So when we talk about the GI tract, we're really talking about, the entire organ system from your mouth to your anus. So this is the system that breaks down your food into blocks that can be used by your body. So it breaks it down and then it gets absorbed from your small intestine mainly into your bloodstream. And then, so, a problem anywhere from your mouth to your anus can in fact impact your GI tract. Usually when we talk about GI disorders, we think mostly about local signs like pain in a certain area or problems with vomiting or diarrhea. But there are some systemic signs. So systemic just means something that you see throughout your body. So a systemic sign of problems with your GI tract could be failure to thrive. And sometimes people have problems with itching throughout their body. And this is can be related to liver dysfunction, can cause itching. So sometimes if you're having a problem and, widespread itching and it's not known why, it could actually be related to your GI tract. So the main thing when we're talking about interventions for people that have problems with your GI tract is making sure that they're getting all of the nutrition that they need. So, if they have a problem with absorption of nutrients, maybe they need tube feedings or TPN, nutrition through their vein or something. So figuring out what's going on and then kind of maximizing their ability to get their nutrition. And then always remembering that there can be some systemic signs like the itching, or sometimes with celiac disease, which is also a GI disorder, they can have rashes. There are certain problems with your GI tract that you are born with. So these are going to be your congenital disorders. So we're just going to go through the list of congenital disorders. The first one we're going to talk about is a TEF, which is a transesophageal fistula. So this means that there's a communication between the trachea and the esophagus. So I don't know if you guys know this. So the trachea and esophagus are right next to each other when you look in the back of the throat. So this would be an instance where the trachea and the esophagus were connected to each other, so that when you swallowed, you would have formula or milk go down into your lungs. So it develops into different types. You don't need to know all the different types. You just need to know that you're born with it. It's a problem with your esophagus, and it normally presents with coughing and sputtering. So when the baby tries to eat, since the milk doesn't go into their stomach, it falls into their lungs and they cough and they sputter when they try to eat. There's something called an imperforate anus. So, you can imagine that, the small intestine and the large intestine meet, and where that tissue meets, there should be a perforation. So those two types of tissue join. When that doesn't happen, that's called an imperforate anus. So it can be something as severe as like a blind pouch where the intestine doesn't end in the anus, or it could be just a really, really narrow anus. So there's a spectrum of problems. Sometimes they need to have surgery to either bring the intestinal tract up to the skin in an ostomy or connect it to the anus. And sometimes they just need to dilate the anus. So meconium is that first stool that you see in babies. So babies should all poop within the first 24 hours. And you should never discharge a baby home until they've passed their first meconium stool. So if you have a baby that's born and they haven't passed the stool, one of the things you might think about is that they could have an imperforate anus. So these kids, will need some sort of intervention. So you're going to make them NPO, not let them eat. A colostomy, that's where you take the end of the intestine and you pull it up to the surface of the skin. So then they would drain their stool, their poop contents out their ostomy. And sometimes, like I said, they need more like dilation or interventions on their anal canal, right where their anus is. Something that kids can be born with, but they're not always diagnosed with right away, is pyloric stenosis. This was one of your discussion questions. So when you have pyloric stenosis, the connection between the stomach and the small intestine is too tight. So you have a hard time draining your stomach down into your small intestine, and that causes this really impressive projectile vomiting. So the baby always acts like they're hungry. They feel like they want to eat all the time because they're just vomiting everything up. And it's really different than other types of vomit because it's really projectile. It's not like a spit up. They just kind of shoots out of their mouth. Obviously, they can get dehydrated. Something that's specific to pyloric stenosis is this olive-shaped mass in the upper right quadrant of the abdomen that sometimes you'll feel. So these kids require surgery. They're going to come in, they're going to be made NPO, they're going to be put on IV fluid, and then they'll have surgery to repair their pyloric stenosis. Celiac disease is an inability to digest gluten. So gluten is in wheat, barley, oats, and rye. So the main treatment for celiac disease is to avoid the foods that you cannot digest. So it's a lot of diet modification. They can't eat foods that have these grains in them. So it causes, problems with absorbing their nutrients. So they tend to get abdominal distension. Sometimes they have like fatty, frothy stools too, because they're not able to digest things normally. There's a couple different ways that it can present. The main thing that you really need to know that it is something that they're, generally you're born with, but sometimes it's not diagnosed right away. The definitive diagnosis is going to be doing a biopsy of the small intestine and look at the fibers of the small intestine, small bowel. And the treatment is just going to be a lifelong restricted diet. So this is something that's really, really hard for parents because so much of what we eat has gluten in it. So having a gluten-free diet is actually something that's really hard to do. So they should really be followed by a nutritionist or a dietitian. And this is one of the ones where you can have like a rash all over your body. And sometimes that, you can't figure out why they have a rash and they end up having celiac disease. It's one of those atypical presentations of celiac disease is a rash. Hirschsprung is another kind of another pooping problem. This one is associated with Down syndrome. So you're more likely to have Hirschsprungs if you have Down syndrome. And this is really a problem with innervation. So they don't have the right nerves and muscle control of their bowel. So there's something called peristalsis where your intestines move in and out. So they move in and out, and that pushes your fecal mass down your GI tract. So they don't have normal peristalsis because they don't have normal nerve input to their GI tract. So, there's a variety. They can be anything from constipation to complete obstruction of their GI tract. If they do pass stool, it tends to be really thin and narrow. And it tends to be something that can be episodic. So sometimes their Hirschsprung's is worse than other times. It's another one, if you were to make a list, if a baby's not pooping when they're born, one of the things that you would think about is Hirschsprung. So you would think about imperforate anus and then Hirschsprungs. Sometimes they're not diagnosed right away. They'll go ahead and pass their stool as a newborn and they'll go home, but then they have problems with constipation, or they have these really thin ribbon-like stools, maybe abdominal distension because they're not able to poop. Frequently they're diagnosed as just being constipated before they actually get the diagnosis of Hirschsprung's. So it can end up causing problems like obstruction because they're not able to get their stool out of their body. But it's kind of more symptom management, since really it's a problem with innervation. There's not really anything you can do surgically. The worst case scenario, they could do an ostomy where they pull the end of the colon up to the surface of the skin and have it drain that way. But usually they're managed symptomally by their symptoms. Meckel's diverticulum is another. This is like an outpouching. It's near the ileocecal valve, and it causes painless rectal bleeding as that little outpouching is inflamed. It's the most common congenital malformation of the GI tract. You see it more often than in boys, and they do surgery on it. The last thing that's in this category of congenital are hernias. So you've probably heard of hernias in the adult population. Can anyone tell me what a hernia is? Generally speaking, you can have them in various places, but what is a hernia? When you say someone has a hernia, what does that mean?
Something didn't close. I know it's like something didn't close.
Yeah, so you get part of your abdominal contents, like your loop of bowel or something, that goes through your muscle wall. So you'll see it pooching out. You'll see part of the abdomen kind of sticking out where it shouldn't. So you can see it in the groin, and it looks like a bulge. You see this in adults. Sometimes you'll see an inguinal hernia down there in their groin. And in kids, they can have inguinal, but it's more common for them to have umbilical. So this is going to be where part of their intestines poke out through where their belly button is. So if you've ever seen a kid with an umbilical hernia, it looks like they have like their belly button is like the size of an orange. It's really, really big. And that's not their belly button. That's their intestinal contents that are pouching out through that umbilical ring. So if you think about hernia, just think about something kind of outpouching. It's their abdominal contents, their loops of bowel that are coming out through their muscle wall. For kids, it's usually congenital, but it can be acquired. So it's considered reducible. So if, like, for me, I've seen many more kids with umbilical hernias than inguinal. It's reducible if you can push it back in. So if you see a kid and they have like a really big looking belly button and you push it in and it goes back in, then it's reducible. But if you can't put it back in, then you're worried that it's what's called incarcerated. So if it's incarcerated, that's really, really tight, and that area of bowel isn't getting the blood flow that it needs. So incarcerated or strangulated, this area of bowel that's pushing out through the muscle wall is not getting the blood flow. So they can be really, really sick if they have this, abdominal pain, vomiting, that part of their bowel isn't getting the blood flow that it needs. So then they would need to have surgery. So those are all of the congenital, and congenital just means something that you're born with. So now we're going to go over some others that are, your gastroenteritis, like diseases of motility. So kids can have vomiting or diarrhea. It's pretty common. In terms of the diarrhea, sometimes they're not tolerating the food that they're eating. They could be eating too much. Maybe their parents are mixing the forbital wrong, or they're eating foods in high amounts of sorbitol or high amounts of sugar that kind of cause fluid shifts in their GI tract. And sometimes it can also be infectious. So regardless of what is causing the diarrhea, you're always going to be worried about their fluid balance and their electrolytes. So if they have diarrhea, try to figure out what's causing it, and then address the cause. There's a lot of education. As nurses, you do a lot of education, making sure parents are aware of like proper food storage, good hand hygiene, making sure, if it is infectious, those gastroenteritises can spread rapidly throughout a family. Kids get diarrhea pretty frequently, so you also have to kind of prepare parents that they can be sick with diarrhea for several days. Vomiting also goes along. Sometimes it has a lot of the same sort of causes. It can be infectious, it can be eating too much, or baby not burping a baby appropriately. You always worry, we worry a lot about the brain. So we've talked about signs of increased intracranial pressure. One of them, especially in kids, is going to be vomiting. And then when you vomit, you're also at risk for aspiration pneumonia. So you vomit and then you swallow some of that vomit, and it can go down your trachea into your lungs. So in terms of, taking care of kids that are vomiting, you need to make sure parents know about proper feeding. You don't want to bottle prop. You don't want to leave babies flat on their back. After they eat, they should burp and then be put on their side. And also older kids, you should make sure on their side. So if they vomit, they don't aspirate. And if they're not able to keep stuff down, they might need to be on IV fluid. Always, as a nurse, you're going to make sure you document things well, how much they vomited, what color. Antiemetic, this is agents to help them stop vomiting. You want to document that, make sure you write down if it was helpful. Diarrhea, I think we all know what diarrhea is. Usually kind of greenish yellow color. It can be infectious. It can also just be an intolerance to what you eat. We say it's chronic if it lasts more than 2 weeks. This is kind of what I was saying. Kids can be sick with diarrhea for several days, and sometimes it's really bothersome from parents. But you need to, keep a close eye on their fluid intake and their urine output. But sometimes those diarrhea illnesses, they just kind of last, and it takes a little longer than you want to get over. But you just need to be really careful about making sure you're staying up with their fluids. And usually they can be managed at home. So if they're really refusing to eat, or if they have a high fever, or they're not really wanting to get up and play, they might need to come in for IV fluid. You need to be able to recognize what dehydration looks like. And you do need to remember that vomiting primarily causes a metabolic alkalosis, and diarrhea primarily causes an acidosis. So I would write that down. Just because it's a common thing to test in the NCLEX and HESI world. So when you vomit hydrochloric acid. If you don't have enough acid, you have an alkalosis. And when you have diarrhea, you lose a lot of base. So there's a couple ways you can remember that: bicarb out the butt or base out the butt. You can also remember acid from your ass. So if you have diarrhea, think about acidosis, and if you have vomiting, think about alkalosis, and be able to try to look at that on a blood gas and be able to differentiate between the two. That's a common thing to kind of be tested on as one of the more difficult questions on like a HESI or your NCLEX. So if you have diarrhea, over time you'll lose bicarb and you'll end up with an acidosis. On the other end of the spectrum is going to be constipation. Kids get constipated all the time, unfortunately. We don't normally do laxatives or enemas in kids. We really start with diet. And then if we do any sort of medication intervention, it would probably just be a stool softener. So constipation is defined as fewer than several bowel movements in a 2-week period. So like having some sort of a stool journal or log is important. And then making sure that you're thinking about what they're eating. Infants that have a lot of iron in their formula can develop constipation, or if they're older, if they're not eating enough fruits or vegetables or not drinking enough water, they can get constipation. So like I said, we normally start with diet modifications, and if they add a medication at all, the first thing they would start with would be a stool softener. We talk about the younger kids a lot in this class because they're just at higher risk for problems. So kids under the age of 2 are higher risk for fluid and electrolyte problems. Their kidneys are not as mature, and they lose more fluid through their skin. And they have a higher metabolic rate. So those are the primary reasons that they're a higher risk for fluid and electrolyte imbalance. But in the age group under the age of 2, you worry a lot about them getting dehydrated. So you're more likely to bring them into the hospital and start them on IV fluids if they're having vomiting or diarrhea. Young kids don't really tend to tolerate fluid shifts well. So we keep a really close eye eye on these kids and have a low threshold from bringing them in. And one of the main things we look about is their urine output. So making sure if they're starting to have a drop off in their urine output, then we're going to be worried that they're dehydrated. And to remember that their kidneys aren't mature until they're around age 2. So if they're able to keep some stuff down, a lot of times we start with oral fluids at home, specifically with vomiting. If they're really vomiting everything, they probably just need to come in and get IV fluid, because you can't really replace fluids if they're vomiting everything up. So, and then diarrhea, sometimes they also do need IV fluid with diarrhea, but it's more common when they're vomiting that they're going to need some IV fluid. You guys should be able to recognize the different types of IV fluid. So who can tell me what isotonic IV fluid is? Like an example. What's an example of isotonic IV fluid that you're going to see in the hospital? And what does it mean to be isotonic?
At 9%, isn't that the 9%?
Yeah, sodium chloride 9% is isotonic, so is lactated ringers. So isotonic means it has the same solute concentration as the blood, so it's not going to cause intercellular shifts. If you give someone an isotonic fluid, the fluid that's in their cell is going to stay in their cell, and the fluid that's outside of the cell will stay outside of the cell. So it's going to be the same concentration as the blood. Whereas hypotonic is going to be less, so it's going to cause cell water to leave the cells and go, I'm sorry, the other way around. Hypotonic is going to cause fluid to move into the cells, and hypertonic will cause fluid to move out of the cells. So something like 3% normal saline is a hypertonic. You would give this to patients that have increased intracranial pressure because it shrinks their brain cells because it pulls fluid out of the cells. And a hypotonic does the opposite. So you kind of need to know what their concentration of their blood is. So isotonic, this is if they have normal blood, but if they have, if they've drunk too much water and their blood is hypotonic, then it can change what type of IV fluid that you're going to give them. So the most common is going to be the isotonic, which would be like lactated ringers or normal saline is the most common type of IV fluid that you're going to give. So when you're talking about fluid replacement, maintenance fluid is just like replacing your normal amount of fluid that you need. Whereas if they're dehydrated and they have a fluid deficit, then you're going to have to give extra fluid to make up for that deficit. We always worry about potassium. So when you start to get dehydrated, your urine output drops off. So you always make sure that they're peeing before you add potassium back into their IV fluid, because if they're not peeing and you give them potassium, they could develop hyperkalemia or a high potassium level. So make sure that if you're dealing with IV fluids, if they're dehydrated and they're not having any urine output, you make sure they're not having any potassium in their IV fluid. On the other end of the spectrum, kids can actually get overhydrated. Overhydrated could be, they just drank too much fluid. It's usually related more to like they're in the hospital and they got too much IV fluid. So it's important that you recognize, how much IV fluid someone should be getting based on their weight, and that you're monitoring patients closely that are on IV fluid, because they are at risk for developing overhydration. If that happens, you would expect them to be edematous and have like signs of fluid overload. If they have overhydration, it depends on what is the cause, but sometimes they will just still be on IV fluid, but on a lower amount. And you're going to be paying attention, just like with dehydration, what type of electrolyte balance they have. Is it a hypertonic, or an isotonic? And then, making decisions accordingly. So an example of this is if you're hypertonic, your sodium level is going to be too high. So then you're not going to drink fluid like tomato juice that has really high sodium. And hypotonic, your sodium level is going to be too low. So in that case, you're not going to want to drink a lot of free water. So you're going to be looking at their fluid status and also their electrolytes, and then choosing the type of fluid that they get based on not just their fluid balance, but also their electrolytes. With overhydration, like I said, there's going to be fluid overload. They're going to be at risk for edema. You're going to be monitoring their weights closely. They can end up with like cerebral edema, so you have to also monitor their neurostatus. So I don't want to confuse you too much with the hydration status. The main points that I want you to remember, I want you to know the difference between hypertonic, isotonic, and hypertonic, and just be able to recognize that you're going to pick your fluid based on what their fluid balance is and also what their electrolytes are. And to remember that if they're not having any urine output, you're not going to put any potassium in their IV fluid because they could develop hyperkalemia. Do you guys have any questions about that? Okay. So, you know, one of the things that you will see as a pediatric nurse is failure to thrive. So failure to thrive is, you know, not gaining weight normally. So there can be a physiological problem. Maybe they have a problem with their GI tract, short bowel syndrome or something like that. Or it can be because of abuse or neglect. So kids come in with failure to thrive. It's important to be really non-judgmental and not assume that this is a neglect case, and always try to give the parents as much support as possible. So obviously, if kids aren't getting the nutrients that they need, they're going to have weight loss, they're going to be irritable. You really sort of worry about them if they're below the 3rd percentile. We talked about in the beginning of class that you really want kids following their growth curve. But regardless if they've always kind of been small, if they're below the 3rd percentile, that needs an evaluation. So just always remembering there's lots of different reasons that someone could be failure to thrive. And, you know, they could have a problem with their GI tract, or it could be abuse, neglect. So you have to be paying attention to what's going on in their social history. It's going to be a multidisciplinary team. Severe cases, you would have to remove the child from the home. It's one of those things, they tend to be in the hospital for several days. So if they could have the same nursing staff, some sort of primary nursing team is best for both the patient and the family. Encourage a lot of education. You can use this opportunity if it is a neglect situation to support the mother. You know, the vast majority of parents really love their kids, so this is not necessarily a reason to terminate parental rights or anything. It could be an opportunity just to do better education and support them on to be, or dad, to be a better parent. So I think failure to thrive can be difficult because, you know, for the nurse, it can be emotionally taxing, but if you could try to have like a non-judgmental attitude and just recognize that, you know, being a parent is hard. Sometimes this just takes a little bit of extra education and support. The last topic, no, it's not quite the last, appendicitis. You guys have probably known someone that had appendicitis or had appendicitis yourself. It's pretty common. A lot of the symptoms are going to be the same as adults and kids. The things that you really need to be able to pay attention to is that it's associated with that right lower quadrant pain. There's a specific term, McBurney's point, that refers to the right lower quadrant pain. You need to be able to recognize that that's associated with appendicitis. So guarding means that they don't want you to touch their abdomen. Rebound tenderness, when you press down, it's not as painful, but then when your hand comes back up, that's when they have the pain. And then if they're in the supine position and you lift their leg, that's painful. And then the primary thing is this right lower quadrant, which is the McBurney's point. So if they have appendicitis, they do need to have it removed. And they're typically much more sick if it ruptures. So the ideal situation is they come in with that right lower quadrant pain and the vomiting, and they get it removed and it doesn't rupture. If it ruptures before it's removed, then they're much more likely to have a significant infection post-op. So, you know, just to kind of advocate for early intervention and having parents come in if they have the fever and vomiting and to get evaluated for possible appendicitis. So we're going to talk a little bit about worms. You're gonna see this as a pediatric nurse. The most common type of worms that you're going to see in the United States are pinworms. And this is something that's hard for families because everyone thinks worms are gross. But it's just to be not judgmental. It's not necessarily a hygiene thing. It's super contagious. It spreads really quickly throughout families or daycares. And certain things, you know, you want to make sure that you're cleaning well, and also that you keep their fingernails short. The eggs live outside of the body. So if kids are sucking on their fingers and they have some of those worm eggs under their fingernails, they can infect themselves. So there's something called the Scotch tape test, and that's you literally put Scotch tape around their anus, and if you see the little worms on the Scotch tape, then you know that they have the worms. And you do treat it with medication. You normally have to treat the whole family because it's highly contagious. So pinworms are really, they itch. So the kids that are really scratching their butt a lot, they could have pinworms, but they don't necessarily make you feel bad. But the roundworms, these make kids really, really sick. So this is not very common in the United States. It tends to be in areas where they don't have indoor plumbing. So this is going to be where they don't have good separation of their stool, their poop from where the kids are playing. So the eggs can survive in the soil for weeks. So if the kids are digging in the soil, they can eat the egg larva and then get sick. And they tend to really have significant symptoms, high fever, a lot of GI complaints. So, you know, you need to make sure you're doing good education with your parents about general hygiene, especially somebody that lives somewhere where they don't have indoor plumbing, and making sure that the kids aren't in an area where they could have access to the eggs. So poisoning kind of falls into this category of GI complaints. So just making sure you're doing good education, making sure that poisonous substances, household cleaners, etc., are out of the reach of children. You don't necessarily have to memorize the information on this slide, but to be able to recognize that the odor of the vomit can tell you a lot about what might be in it. So getting all the information you can, if you ever have to call poison control, including what it smells like, is really useful. You should encourage every parent that you know to have the Poison Control Center on their phone number, on their refrigerator, near their phone, whatever. This is it's a 24-hour hotline. It's a nationwide number all over the country, and they're very useful. And you can always call and ask, you know, if you think your kid got into something, you can call the poison control number. We don't recommend parents to activate a charcoal or vomiting or gastric lavage at home. Sometimes they will do it in the emergency room, but there's really a limited time frame. You have to do it within an hour of ingestion or it's not effective. And it's not just prescription medications. You need to be careful about over-the-counter medications also. And there's lots of different things that kids can have access to. So, you know, snakes, plants, carbon monoxide, being on the lookout, making sure kids are being appropriately supervised. Lead poisoning. Does anyone know where do most kids get access to lead? How do they end up with lead poisoning?
At homes that's built before 1978.
Oh my goodness, so good. So yeah, it's really most common in paint from the early 1970s. So older homes where there's chipping paint and they ingest the paint chips, that's the primary reason where they get lead. So, you know, stair rails, windowsills, crumbling plaster, it tends to be the older homes. And the main reason we really worry about it is that lead poisoning can cause mental retardation if it's not treated early. So if they're having risk factors depending on where they live, they usually do a serum blood test to check the lead level. So in the beginning, it presents as a lot of different things. They're just kind of not feeling very well, weakness, irritable. But in the later stages, that's where they have their nervous system involvement and can cause mental retardation. So there is a chelation therapy we talked about with when you have iron deposits in your blood, you can take medication that binds the iron and helps remove it. There's chelation therapy for lead poisoning also, but you really don't want it to get to that point. You really want to be screening early, making sure parents know, especially if they live in an older home. And then the last thing is foreign bodies. So kids, they put everything in their mouth. So you have to be on the lookout. Most of the time, regardless, it just kind of slowly works its way through the GI tract, but they need to call if their kids swallow something because it could be in the trachea, it could affect their respiratory. And usually it goes down the esophagus, but not always. So, and just to make sure parents know that it can take up to 6 days for it to come out. So you need to make sure that they call and see if any follow-up is needed. And also just to be aware that unfortunately kids tend to swallow a lot of things. Most of the time it's not a problem, but they need to always call their pediatrician and let them know. Do you guys have any questions about the GI tract information? Okay, we have one last Kahoot. And then you guys will be free to go. All right, I'd love more of you. I see some of you sitting here but not joining. We got to get some more people on here so we can get out of class on time. Samuel, are you in? Did you join the Kahoot? Christopher?
I'm in.
All righty. How about Deschantel? You on the Kahoot? Sia?
I'm in, Professor.
Okay, thank you. I see some names popping up. Denicia, Brittany. Okay. All righty, thank you. Which finding in a newborn is suggested of a tracheoesophageal fistula? Failure to pass meconium, palpable mass in the sternal area, visible peristalsis across the abdomen, or choking on the first feeding? All right, yeah. So this is where there's a communication between the trachea and the esophagus. So when they swallow, the milk falls down into their lungs. So it's going to be choking on their first feeding is the thing that you're going to see. They have to have surgery before they go home. They can't go home with that. A child is brought to the clinic with vomiting for the past 2 days. Which acid-base imbalance does the nurse expect? Alkalosis, acidosis, hyperkalemia, or hypernatremia? All right, so very good. So alkalosis for vomiting and then acidosis for diarrhea, to try to remember those two. The nurse is interviewing parents of an infant with pyloric stenosis. What would the nurse expect the parents to report? Constipation, projectile vomiting, bad appetite, or diarrhea? Projectile vomiting, very good. So what instructions will the nurse give to parents about preventing the spread and reinfection of pinworms? Keep the children's nails short, dress the child in loose fitting underwear, clean the bathroom with bleach solution, or wash the bed linens in cold water. All right, very good. Keep their nails short. Their little eggs that cause the pinworm infection can live under the fingernails. And when they suck on their fingers, they can reinfect themselves. A 2-year-old child experiences constipation frequently. Which food would the nurse recommend? Cooked vegetables, pretzels, whole grain cereal, or yogurt? All right, so the whole grain cereal is going to be better than your cooked vegetables. Then when you cook them, they don't have the same fiber. It doesn't do as much for the constipation. And yogurt is dairy products can be constipating. So you're going to give them the whole grain. A mother calls the PCP office because their child swallowed dishwasher detergent. What's the most appropriate action? Induce vomiting by giving children the syrup of iapecake. Give the child activated charcoal mixed with juice. Give the child milk to soothe the mucous membranes, or take the child to the local emergency department. Yeah, so the best thing to do is go ahead and bring them into the emergency room. You're not going to have the parents inducing vomiting at home or doing anything like that. This needs to be done in the emergency room, and you don't want to soothe their mucous membranes. You don't know how much they took, and dishwashing detergent can be caustic, so it's best for them to come in. The nurse has reviewed dietary restrictions for celiac disease. Which grain will the nurse advise that celiacs can eat? Wheat, rice, barley, or oats? This one was tricky. So it is rice. So the wheat, barley, and oats all have gluten. So celiacs cannot eat gluten. So they can eat rice though. Why are infants more vulnerable to fluid and electrolyte imbalance than adults? A greater percentage of the infant's body weight is extracellular. Water needs and losses per kilogram are lower. They have a smaller body surface area, or they have a slower metabolic rate. All right, good job. Yeah, a greater percentage of their body is extracellular. They lose more fluid through their skin. Very nice, you guys. All right, is that J for Jessica? Very good. Okay. So I will post the Kahoot with the lecture either later today or tomorrow morning. And then if you guys have any questions, you're free to send me a message. Please remember that you have a quiz next week. And the quiz is over next week's material. So take a look out for the Kahoot so that you guys kind of have a general idea of what you should be focusing on for your quiz. And unless you have any questions, you guys are free to go. Bye-bye.
Hello, I have a question for you.
Yeah.
What availability did you have for the rest of the week? Because I know you sent me Tuesday and Friday. I'm pretty sure it was 12 and 4 to go over the exam.
Yeah. So that is best for me. I have 2 students today, but I do have time this afternoon, or Friday would also work for me. When or Thursday, to be honest with you. What's your schedule like?
What time this afternoon would you be? 'Cause I know you do have 2.
Yeah, so I have somebody at 12.
Mhm.
And then now I could do like 1 p.m. Eastern.
I have a class
Okay.
at 1 p.m. So
Do you have time on Thursday?
what time Thursday?
Thursday, I'm really free at any time. You can tell me what time and I'll make it work.
Let me see. Because I do have classes up until about maybe 1 p.m., 1:30 on Thursdays. So anytime after that.
Okay, how about Thursday at 2 p.m.?
That works.
Okay, sounds good. I'll see you then.
Thank you so much. Have a good day.
You too. Bye-bye.
Bye.
All right, Tiara, are you there? Are you there, Tiara?